In this video, we're going to talk about paying for healthcare, particularly the role of government in paying for healthcare, and then a little bit about how government can actually provide healthcare as well. So first we need to touch on health insurance, just kind of typical employer-based health insurance, which is among the most common ways that people can actually pay for healthcare. We don't pay out of our pocket, we pay an insurance company who then pays the hospital and physicians directly. Now, health insurance became really a thing, or employer-based health insurance really became a thing during World War II. At this time, all of the resources were going towards the war effort, and that included any excess salary. So there was a national wage freeze. There were no raises, there were no bonuses. The amount you got was the amount you got for multiple years. So as a way to both entice workers coming back from the war to work in factories and to attract the most talent, companies started offering health insurance as an employer-based benefit, which is not necessarily something that was discussed before. This was aided by unions who collectively bargained for more benefits because they couldn't bargain just on salary. They successfully bargained for employer-based health insurance. Now, insurance itself in the past has typically been fee-for-service, and that is as the insurance holder, we pay a monthly premium. We just give the insurance company $100, $200, $300 a month. And then the company pays for the cost of whatever medical interventions that you do. So a physician's checkup is one price that they would pay. A blood test is another price that they would pay. A surgery is a third price that they would pay. And there wouldn't be this, your premiums don't just go straight to the doctor. Your premiums go to the insurance company, and then the insurance company will bargain with the doctor for however much they think each service is worth. Now, you can get healthcare without health insurance. Providing free or cheap care, particularly for the poor, has a long history. It's not just U.S. history, it's just kind of world history, which is a topic for a separate discussion. But often things such as dispensaries for pharmaceuticals were associated with medical schools, and there's often been clinics, and there currently are clinics within public health departments and again associated with medical schools. Another way currently that people from low-income populations can get healthcare are through community health centers. And these are health centers and clinics specifically designed to serve the uninsured and the underserved population. They're also known as federally qualified health centers, which you may see as they're designated elsewhere. And they're called federally qualified because they must meet certain specifications. So they must be located in a medically underserved area or in an area with medically underserved populations. They have to provide comprehensive primary care, although they don't have to provide specialty care. They have to have a sliding scale for their services. So the lowest income individuals pay nothing or next to nothing, where higher income individuals may have to pay full price. And they actually have to be governed by the community themselves. So there has to be this community board where members are actually patients of the community health center, which is an interesting aspect. And this is a map, the distribution of community health centers in the U.S. by state. This isn't a rate of healthcare centers, this is just the total number of health centers for each state, and it follows a typical distribution. The highest population states have the most health centers, which is a good thing. So Texas, California, New York, and Florida in no particular order. There are much fewer here in New England, although Massachusetts has a high amount, but there should be fewer just because we have a lower population rate. So in Rhode Island, the population here is only about 1 to 1.2 million, so you wouldn't expect a high density of them even if we have the same rate of health centers as other states. So government-sponsored healthcare. So a large amount of people have employer-sponsored health insurance, or they pay out of pocket for premiums for health insurance. But another large segment of the population, and maybe even a more important segment of the population in terms of paying for healthcare, because we all kind of contribute, are people who rely on the government to pay their health insurance for them. And this is through Medicare, Medicaid, and the CHIP program. So Medicare, this was passed in 1965 as part of as an amendment to the Social Security Act. It's basically providing health insurance to anyone 65 years or older or receiving Social Security disability. So essentially, you retire from work, you're no longer eligible for employer-based health insurance. The government now steps in and says, we will provide the health insurance for you. Now, the eligibility has been changing over the years, basically adjusting on how long we're living and how well people how long we're working, and to keep the program solvent. But the original eligibility requirements is 65 years old. This is a federal program. It is paid for completely by the federal government, and it's administered completely by the federal government. This differs, before I get to that, so Medicare does have 4 parts. Part A is the hospital insurance program. This covers all hospital services. So if you need surgery, you have a heart attack, you have an overnight stay in a hospital, Part A will cover it. And it's free. Everyone is entitled to essentially this emergency intensive health insurance once they are of age or on Social Security disability. Part B, you do pay a small premium. And this is the supplemental medical insurance program, and this covers outpatient visits. So this covers your primary care doctor. This covers your specialist visits outside of the hospital. Part C also requires a premium. This is the Medicare Advantage program, so it allows you to use Medicare dollars to enroll in a private insurance plan. Not everyone does this, and the benefits of this vary depending on who the source is, but just be aware of it. And then finally, Part D is the newest part of Medicare. It was passed in the early 2000s. It requires a premium, but this is your prescription drugs. So prior to Part D, Medicare wouldn't actually cover prescription drugs. So 4 parts of Medicare. 1 is free. This is essentially hospital services. The other 3 parts do require some sort of premium to get outpatient services and try to use your money to enroll in private insurance plans or to get prescription drug benefit. Now, Medicare differs from Medicaid in a variety of different ways. They were both passed in 1965, part of the same bill. Where Medicare, you were eligible essentially based on age and disability status. Medicaid, you're eligible based on income. So if you are below a certain percent of the federal poverty level, you can qualify for Medicaid. It's essentially need-based health insurance. Now, this program again differs from Medicare because Medicaid is paid for by the federal and the state governments, and it's administered by the state government. And for being at the state level, it means each state can create their own regulations and their own cutoffs. So Medicaid eligibility does vary by state, and sometimes very widely. So this is the Medicaid eligibility for children in the U.S. by state. So on the x-axis, those are all the states. On the y-axis, this is the percent to federal poverty level that you need to be below in order to have your child be eligible for Medicaid. And to give a reference point, the federal poverty level for one single adult is about $12,000. For an adult and a child, I think it goes up to $20,000, something in that range. So it's a really, really small amount of money. At the low end, you have states like Utah, Idaho, and Arizona, where if you are an adult with one child and you're 150% or less of the federal poverty level, you can qualify for Medicaid, or the child can qualify for Medicaid, excuse me. At the higher end, you have states like Maryland, New Hampshire, and Washington, D.C., where you can have up to 300% of the federal poverty level. So you can actually make a fairly decent living and still have your child be eligible for Medicaid. Pregnant women are also required to be covered by Medicaid. The eligibility requirements are very similar between pregnant women and children in each state. There's always some variability, but you typically have the same kind of pattern. So at the low end, Idaho, Louisiana, Oklahoma, you're at that 150% level or less, and at the high end, Wisconsin, DC, now Iowa, you're at about the 300% level. But in general, these are a little bit lower, although they follow the same pattern as Medicaid eligibility for children. If you are the adult, a caretaker of a child on Medicaid, you do have the right to Medicaid as well, depending on your income status. But here's where it gets tricky. Here's where states wildly diverge from each other in terms of Medicaid eligibility. You have some states, such as Alabama, Texas, and Arkansas, where their limit is like 25-30% of the federal poverty level. So you literally have to make less than $10,000, less than $8,000 a year to qualify for Medicaid as a parent of a child, even if your child is already on Medicaid. On the other hand, you have states like New York, Alaska, Connecticut, DC, again, is really high, where you're in that 100-150% level. Again, you're not. This isn't for pregnant women. This is for essentially healthy adults who are taking care of a child or an adult who needs caregiving. So Medicaid eligibility varies by state. It varies by individual, children, pregnant women, adults, and there is wide variability. So in certain states, you could get very good coverage and you could actually make a decent amount of money and still qualify for Medicaid. In others, and I pardon my bluntness with these words, you have to essentially be dirt poor as an adult at the very least to qualify for Medicaid. And then I do want to mention the Children's Health Insurance Program. This is very interesting history. So it was passed in 1997 during the Clinton administration after a total health care reform effort failed in 1993. It's a federal and state partnerships. It's very similar to Medicaid. They go basically 50-50 in terms of who pay for it, but it's administered by the states. So it basically serves children who aren't on Medicaid or aren't on a parent's health insurance plan. And it insures minors up to 19 years old. So essentially, if your employer-based insurance only can cover you and won't cover your child, CHIP can fill that gap. It's basically income-based, but again, it's varies between the states. I say this has an interesting history because the Children's Health Insurance Program, which was a bipartisan effort, was just allowed to lapse. The federal government failed to renew CHIP funding just last month. Now, I realize I go on soapboxes a lot of the time, but there really is a lot of politics involved in public health, and this is one of the prime examples. I have no idea why this program was allowed to lapse and why funding was not renewed for it. I don't really want to know because of kind of the implications of it. But this is a program which had support on both parts of the aisle, and there's very few people out there who say, you know what, children, you need to suck it up, you need to find your own health insurance. Like, these are the most vulnerable people in our society, and despite all of that, this program, in the next few months, will cease to exist without more federal dollars. Despite the country not having a universal healthcare system, there is government-run healthcare. We do have that. One is through the VA system, which provides medical care for injuries suffered among veterans during service and medical care for low-income veterans. And we do have the Indian Health Service, which provides federal health services or healthcare services to American Indian and Alaska Natives. So keep in mind, we don't have a universal healthcare system, but we do actually have government-run healthcare in the U.S. We also have government-required healthcare, and this is through the Emergency Medical Treatment and Labor Act. Essentially what it says is that if you go to an emergency department, they're required to treat you regardless of your ability to pay and be stabilized. So if you're having a heart attack, you can go to the ER and you'll be fine, and you'll get care. You may not be admitted and you may not get the most intensive care. You may not be able to follow up with specialists to create plans when you survive, but you'll at least be stabilized and treated essentially for free if you can't pay on your own. And this leads us to the Affordable Care Act. A big topic, but absolutely worth mentioning if we're going to talk about health insurance and the government's role in healthcare. So it was passed in 2009. The idea behind it was to ensure universal access to health insurance. It does not ensure universal access to care. And that's something that's very important to realize. This is not a universal healthcare system. It's essentially creating a universal health insurance system, whether through government means such as Medicaid or through the private insurance system. And it was passed with the idea that hopefully we can reduce the growth of healthcare costs. So what did it do? So some of the things that it did is it said that health insurance company or health insurance plans must cover 10 essential services. These include things like emergency services, hospitalizations, maternity and newborn care, which not all of them did, prescription drugs, and then preventive and wellness services. So not all health insurance plans prior to this actually covered your annual physical, which seems ridiculous. That's the best way to ensure someone's health. It said you can't be denied insurance based on a pre-existing conditions. And this is a rough list of all things that people were denied health insurance coverage for because they were considered a pre-existing condition. And here I've highlighted some of the kind of the most egregious ones, at least in my mind, and you can differ from me. So if you were obese, health insurance could decline providing you health coverage because of your obesity. If you're pregnant, they could decline new coverage for you because of that pregnancy. Diabetes, cancer, there's also heart disease on there. There's genetic diseases, so like Parkinson's, which has a genetic cause. There's HIV, AIDS, Alzheimer's. All of these things were reasons that that health insurance companies were denying people access to health insurance and ultimately health care to essentially protect their bottom line. Companies can't do this anymore, at least through health insurance. Employer supplied health insurance and health insurance bought through the exchanges. Now, again, the Affordable Care Act was a universal health insurance law. So everyone has to obtain health insurance or they pay a penalty. This is the mandate. So either get it through your employer, get it through government sources, Medicare, Medicaid, or you buy health insurance through the exchange and through these online healthcare exchanges which were set up by this law. There were some limits placed on insurers in terms of where your money goes. So prior to this, you paid a premium and health insurance companies could do whatever they wanted. They charged you as much as they could, they paid physicians as little as they could, and they took as much profit back. Now, only 20% of your premiums you pay into coverage can go towards non-medical expenses, to go towards administrative expenses, essentially. So 80% of the premiums you pay are going to your health care or the health care of the people in your insurance risk pool. And we'll talk about that and what risk pools are in this lecture. And premiums can only differ between one individual for another based on the number of people in the plan. So is it a plan just for you, or are you enrolling your whole family? They can change based on your geography. So this is called community rating. And this is much different than the old system, which was based on individual rating, so how healthy you were. Now it's essentially how healthy your community is, and that's where your health insurance rates can change. So if you're complaining that your health insurance premiums are too high, even though you're a very healthy individual, essentially look at the people around you. They might be increasing your premiums without your knowledge. Age, so older adults can be charged 3 times as much as younger adults. In the past, this was 5 times, 6 times, 10 times that older individuals were being charged as young adults. And then the only behavioral thing people can be charged more for in health insurance is tobacco use. So if you use tobacco, your insurance premiums will ultimately be higher. It's just, we know so much about tobacco, it's indisputable how much disease it causes, it's indisputable how much money it costs to treat tobacco-related diseases, that it was actually included in the ACA. And finally, to meet that health insurance mandate, the ACA expanded Medicaid coverage to childless, healthy adults. So remember, when Medicaid was put into place, it covered children, pregnant women, and the caregivers of children. It didn't include healthy, childless adults. If you are an adult and you are single, you are healthy, you're not on Medicare, Social Security disability, you did not qualify. You couldn't get Medicaid. What the Medicaid expansion does is allow those people to be eligible for Medicaid at a reasonably high limit of the federal poverty level, 138%. Above that, you have to get, above 138% of the federal poverty level, you have to get health insurance on the exchanges. And this is a map as of, this is last summer, although I don't think it's changed since then, of which states have actually expanded Medicaid. The states in blue have expanded Medicaid. The states in this orangish have not at this time. A majority of states have. And Although the ACA was written as basically a mandate that states had to expand Medicaid, due to several court cases, it turned into an option. So states can actually opt out of Medicaid if they chose to for their population.